like to start by saying good morning to everyone, and thanks for joining this really important and exciting webinar today. Today we're going to begin with this webinar presentation by briefly covering how healthcare costs have trended upward for years, with perhaps the most significant uptick occurring between 2019 and 2020. Next, we will feature a case study from a company that has managed to reverse that trend. We'll get a glimpse into how this company initiated a transformation that ultimately enhanced their health plan to continue providing a rich benefit package while achieving substantial cost savings. The webinar will proceed to outline the solution that the plan initiated to help deliver on their business objectives, and we'll begin by hearing from Sean Garrett, Chief Operations Officer for PLEXIS Healthcare Systems. Then we'll go to Paul Mackey, Vice President of Plan Administration for Alliance Coal, and Al Newton will join us as Director of Pricing and Contract Management for Alliance Coal, and Jeff Winslow from Payer Compass, the Director of Partner Success, will join us afterwards. The webinar presentation is set to go for 45 minutes with a 15-minute question and answer session to round up the hour. Excuse me. If you have any questions, please post them in the chat, and we'll make sure that they're addressed during the Q&A session. Appreciate it. Thank you very much for joining again. Once again, good morning, and let's begin the presentation with Sean Garrett, PLEXIS Chief Operating Officer, and he begins the webinar presentation. Thank you, Sean.
Thank you, Dennis. I want to make sure everyone can see the screen here, the welcome screen with the discussion topics outlined. Okay, we'll get going. So as Dennis noted, the discussion today, we're going to talk about at the beginning, what I think is not uncommon knowledge, healthcare costs and the trend, how it has continued upward. To Dennis's point, the Alliance Coal case study and how they've managed to buck the trend and reverse that cost or bend the cost curve. And then we'll go into the solution approach with how that was done with the plan outline, the approach to the plan, the direct contracting, and the technology that helped support that, part of the integrated solution approach that helped support that. So just a quick quote here, and again, your mileage may vary with these numbers and what you have seen, but I don't think anyone can dispute that in the United States, healthcare spending has increased year over year. It used to be double digit as a common number, and then in the 2010s, the rate of increase decreased some, but it was still pretty significant. And so when we look at these numbers, 9.7% from 2019 to 20. That there again, we're approaching that double digit. It was double digit in certain parts of the country, but the average was, over 4% for the preceding 7-8 years. This is common, and what was uncommon was seeing, any plan, any type of plan, bending the cost curve and decreasing costs. Now, it's not to say that some plans didn't do that, but the way they did that was typically through, one of three approaches, which was purchasing additional insurance to help cover catastrophic loss, stop loss reinsurance, and or alternative coverage, or whereby they basically went to a high deductible plan to minimize costs, and then the employer would help with maybe a MEC plan, something like that, to help cover the out-of-pocket costs on a high deductible for their employees. Alternatively, they may have coupled that with an increase in or cost shift to the employee, whereby the premiums went up and or the member responsibility or out-of-pocket costs for the employees went up. And then lastly, we also saw a common tactic was to just decrease the benefits. So maintain costs, but decrease the benefits. So that meant fewer service options for the plan members, potentially maybe restricting to a limited network in which they could receive services, or allowing fewer visits or units of service throughout the plan year. So, and we've also seen even when employers chose to employ any of these tactics, costs still potentially went up. So that's an unfortunate scene with the healthcare system in the United States, but there are ways to address this, and so we're proud to work with a partner, colleague, and client of ours, Alliance Coal, to share their story on how they approach this. And so I'm going to transition this over to Paul Mackey to discuss how Alliance Coal was able to bend that cost curve in the other direction. Paul?
Okay, great, Sean. Thank you very much, and thanks everyone for your time. And particularly want to say thanks to PLEXIS and Payer Compass for the partnership that we've created to allow us to be successful at this effort. What does bull by the horns mean? To me, it means two things as sort of a maverick in the industry. One is we have forced transparency. We've forced the data that we couldn't get a hold of to become transparent, so we could make intervention decisions and we could create programs that we could otherwise not do. So we'll talk about our journey to get here. And the second thing is we focused on price per unit of care. And the third thing is we focused on the number of units consumed. Let me tell you a little bit about the plan sponsor and the employer that has sponsored this plan. I've been with Alliance Coal for 35 years. And the last 17 years, we've been actively developing a strategy, a healthcare strategy that we've implemented, which in 2019 included implementing and going live January the 1st of 2020 with being our own claims processor. So we're fully self-administered. We haven't had stop-loss insurance since prior to 2006, so we understand risk. And we've done a number of things along the way that's created and gently transitioned us from being sort of a traditional buyer by using a PPO like Blue Cross, which we transitioned away from in 2008, to a TPA, web TPA with a PPO network, until 2018 when we onboarded Payer Compass, who helped us begin processing our direct contracts. In 2008, we began negotiating and becoming aware of in the marketplace what our contracts were, and we moved from our TPA vendor, who was using a platform that's not quite as robust as what Payer Compass has. It gives us more visibility, and then fully operationalize a fully self-administered just for Alliance Coal's business in 2020, 1/1/2020. So Sean, if you'll go to the next slide. Thank you. So the first thing I really want to talk about is what we do differently about the plan design. So as Sean said, our strategy is not to shift cost. Our strategy is to create an integrated health plan. And what does integrated health plan mean? One of the key values of our plan is we have on-site clinics. We've had those clinics. We began building those in 2007. We have an on-site primary care clinic at each of our locations, and all of our employees and spouses and children are eligible to go to those clinics and receive primary care without charge. And what's really nice in today's environment, whenever you're spending $5 a gallon on a gasoline, which is really hitting everybody's pocketbook, it's really nice to have an affordable healthcare option, right? And so what we've seen with this strategy is we're going to show you that not only is it a lower cost, but it has really meant something culturally to our employees, our company. Strategically, it's given our leaders a competitive advantage in the industry, and our employees prefer to work with Alliance Coal. We're a union-free coal company, an underground coal company. We're not an easy industry, so we consume a lot of healthcare relative to other industries out there. But this on-site clinic and this idea where the plan can use its information. Obviously, we participate in HIPAA. We're somewhat separate as an ERISA plan from the employer. We are fully HIPAA compliant. But we are able to get data and develop programs that integrate the care people receive through our direct contracts or through them choosing a non-direct arrangement, so that the folks can actually get a better experience of care and a better outcome of care. You're going to see that reflect in our numbers. So integrated care means purchasing and consumption are able to be facilitated so they're not disparate. If you are purchasing from the common carriers are from a PPO network, you understand very quickly that the lack of transparency prevents you from understanding what's really going on with your data, what's really the cost of a price of a unit of care, and how to build a plan or how to build strategies to make a difference. So this is not easy, but it's possible. And these two vendors that we've got with us have helped make that so. So our arrangement, our plan, we haven't materially changed our plan over the past 7 years. What we have done is made it much more of a choice. You can choose Alliance Direct, where there's no premiums, no deductibles, no copays, no co-insurance. It's 100% benefit. Obviously, we have no premiums. So we really want to encourage people to make good choices, or what we think are good choices, but they don't have to. They can choose to go non-direct. They can choose to go to their favorite provider or favorite X-ray or imaging center and MRI, but there's a very real difference in what price we're able to negotiate between an Alliance Direct facility and a non-direct. So if our employees want to make that choice, they get the opportunity to play that difference. And we've seen 80+% of our folks steer toward the direct payments. Now, some other things you should understand about our plan: we have a medical director of treatment and through our on-site clinics, and we have a medical director of payment who works primarily with the plan and the nurses in care coordination and care navigation that really help facilitate sort of consumption. So we have a very rich, if you will, medical contingent that helps us. And you're going to ask, what does that cost? Well, we find that it costs roughly $125 per employee per month to offer on-site care for our folks. And we spend less than $1.5 million a year with our medical necessity UR med management program. So when you add those things all together, the additional burden, if you're spending $55 per se per employee per month for a traditional carrier or a TPA model, for an additional $45, $50, you can get the full money, but you have to do it yourself because this model is really not available out there. So at the bottom of your screen, just to kind of compare, we compared the Middleman Index, what is generally being paid by insurance. You can see that single family coverage, obviously we're paying $3,000 to $7,000. People are paying an additional $2,000 to $5,000 in out-of-pocket deductible costs. So it's, Americans are easily paying $10,000 to $20,000 plus for coverage if they don't have a health plan like ours that make that available. Now, the cost to the employer, and let's go on to the next page. I want to kind of talk through the next slide. So here's our cost trends over time, and the green is the total cost per employee per month. And as everyone on this phone call knows, you can manipulate numbers, and you'll see a quote from our folks in the medical actuary group and our broker of record who's validated these numbers and has been working with us for more than 45 years. So the top numbers here are a green number per employee per month. That's obviously in your financial sheets. That's the bottom of the financial sheet when you hold everything ceteris paribus, economically to one factor so that you can see what other factors move in your financial statement. So if you look over time from 2015 to 2021, we dropped our total cost by 11%. So that's a $9 million advantage financially just for the employer, not even considering the impact to employees. So if you add the employee benefit to this total sort of equation, you could easily add 15 to 20 million more dollars a year to what this is worth to our folks. The yellow dots there were showing the actual claims cost, and that's really what today's seminar is about. It's claims, so we dropped claims by 7% in net plan spend, and then we look at RX cost on the bottom. And by having more medical people involved in your program, you can customize your formulary. We spend about 13% of our total spend on RX, which is really remarkable in and of itself, and that's probably another webinar, but that gives you the bottom numbers, and we've already sort of talked about what other people do. So if you go ahead and go into the next slide, Sean. This is a quote from our friends at Summit. Todd Rowland is president of Southern Financial, and he can speak to, we're really not playing funny games with the numbers, but this really is a viable strategy because it seems very, almost too good to be true. So next slide, if you don't mind. So I want to take you through this slide. There's got a lot of numbers, but this will explain why the strategy works, because this is a financial and a healthcare strategy. But if it doesn't work financially, the CFOs and the CEOs in this country are probably not really interested in its implementation. So let me take you through the top of the financial sheet and why does the strategy make sense to think about. And then as we go forward, the rest of the discussion will be about how Payer Compass and PLEXIS's software applications that work together and work with us to make this possible. And I think it's better to kind of start with the financial reality and work backwards. So if we look at the top number on the top left, total gross bill charges at 128 million. This was actually what our gross charges were in 2015. In 2015, we were with a PPO network, we were with a TPA. We were focusing on, the bottom line number, the PEPM, but you really have to begin at the top line number, because how you configure your system, how many duplicate claims you have to process, how claims are being adjudicated, what's being read in the data files, those are pieces of the business that weren't available to us. And so you can see in 2015, we really only had 2 reduction numbers that we could parse out because our transparency to the numbers weren't as they are today. And so the first number that we could see a reduction in, or the impact, is, well, how much of a discount? And I hate the word discount, but this industry talks a lot about discount. What was the reduction in contract value between total bill charge and the net plan paid? We attribute in 2015 that 30% reduction there from the less write-off or contract value. That would have been the discount we were receiving. However, as you see over the side, when we implemented this process, we improved our direct contracting. We had a benchmark, and we use Medicare as a benchmark to know what a relatively fair price is. You can see we doubled that reduction or contract value to $64 million. Now, I'll say again, you have to look at the rest of your financial sheet, because what you're not seeing here is you're seeing a reduction from 128 million to 102 million dollars. So that's a 20% reduction. But what you're not seeing on the sheet, because you got to look, is how many people were covered, right? So we actually reduced our covered lives by 34%, but the top line number only decreased by 20%. But still, it's pretty significant, but it speaks to how do you get control of your data. So the next thing we'll say, ineligible charges. In 2015, we were auditing almost every claim that was above $20,000 to see the practices of billing practices of providers. And we were quite offended, actually, by the practices we discovered, the errors that occurred. And it was almost like, it was like errors become intentional. And as we got into understanding that we had to get control of the configuration of the system to force consistency of billing and remittance of claims, then you can see to the right, we were able to break down those reductions and those management factors by more factors. So let me go through them real quickly. The coordination of benefits obviously went from, we couldn't really identify it, to 1.7 million. Ineligible charges, how our plan is designed, we obviously don't pay for cosmetic surgeries, things that aren't medically necessary. We can attribute clearly to 4.4 million, the ineligible charges. As you come down to less planned benefit limits, again, So you get down to the bottom line there. What's allowable? The allowable charge is really the most important sort of pricing and top line number to kind of compare. So we went from a plan allowable 70.9 million or 55% of bill charge to 30.4 million or 30% of bill charge. So obviously, you know, 20% plus increase in a reduction of the allowable plan charge. And what you're seeing there really is a move from about 350% of Medicare on average to around 160, 170% of Medicare when you're comparing to a benchmark. So did it change the actual practice of medicine or outcome? Absolutely not. Did it change what people are paying out of their pockets? Absolutely. So it just pays to know what things cost. And if you're the plan sponsor and it's coming out of your pocket, and you should understand if there's ever a mistake made in the payment process, you, the plan sponsor, will pay for the mistake. And the problem is, without the transparency, you'll never know, right? Because you have to have control of the configuration in the system and more access to data to really understand what that third-party administrator is doing and what programs you need to implement, how hard you need to work in direct contracting to make that up. So we transfer or shift about 2% of claim costs to our participants. That's been consistent. We transition or transfer about 24% of drug costs, and that's been consistent. But you can see the difference there in that plan cost to the bottom line over the top of the financial sheet. So if you don't mind, next slide. I'll turn this back over to Sean. You and Jeff may have some additional comments.
Yeah, this will be Al and Jeff to talk about, you know, everything that Paul just said. Now that was the what and the why, and now Al and Jeff will speak a little more to the how.
Sure, thank you, Sean. I'll go ahead and take that. So Paul is the visionary, and he's the one that kind of came up with, he set the strategy and identified the path, and then the rest of us stepped up to go ahead and implement it. And I joined Alliance Coal just over 4 years ago, and was before we had implemented QC. We had just brought up Visium, Payer Compass's repricer. So I'm just going to kind of talk about the process of shifting to being fully self-administered, and just kind of give you guys a little bit more of the flavor of how that happened and some of the reasons that we made the choices that we did and the whens and the whys. We had an overarching objective to go ahead and take on full control and hands-on administration of our plan. As Paul stated, we're fully self-administered, and that includes we direct contract with providers. We also go ahead and have a significant role in helping members get directed to the most appropriate provider based upon the circumstances. And we also have full control and full administration of our claim processing and payment cycle. So in order to kind of achieve the numbers that Paul reviewed with you on the slide a couple slides ago, you know, price, we learned that price is the most critical component. It all starts with both setting the right rates, both for direct contracts or in-network contracted providers, and how you pay and process your claims for your non-contracted providers. So we took a pretty hard look at how we are pricing claims and developed a three-phase approach to go ahead and get to where we ultimately wanted to be. Phase one was we were using a third-party claim processor. We did not do that in-house, and we implemented Visium as an external repricer. And we sent all of our claims, with the exception of vision and dental, through Visium for claim repricing. What we had in-house at the time was member and provider services, care coordination, care navigation, UR, and pre-authorization. We also brought our contracting efforts more to the forefront and dropped the PPO networks. So we actually reached out to providers in the areas where we had members, participants, and negotiated contracts with them. our objective in all of those was Medicare-based pricing. And some of the reason for Medicare-based pricing is, number one, it's a pretty it's a solid industry benchmark for how claims are priced and where claims are priced. And not, providers will say that they lose money on a lot of the Medicare reimbursement rate services, for Medicare reimbursement, but the reality is it's a really good place to start. And so we apply a multiplier to the Medicare rate. So for example, our blended rate might be 150% of Medicare for a particular service. And we start from there and negotiate using the Medicare pricing as an industry benchmark. The other advantage that is really critical to us as a small plan is Medicare publishes those fee schedules. And so that's not something that we have to go ahead and maintain on a consistent basis. We don't have to go ahead and build new fee schedules for how are we going to pay a particular procedure or an outpatient visit or durable medical equipment. We don't have to go out there and create those fee schedules from scratch. We go ahead and through Visium, we use the published fee schedules, and then we apply the plan multiplier based upon either our SPD rates or the contract rates. The other advantage to Medicare pricing is that we are able to apply the Medicare claim edits. So if you're doing a typical, in the old days, the old way of doing things, and a lot of the PPO networks are still applying this, is a percentage of bill charges. You are paying a percentage of bill charges for services that would not be reimbursed separately under Medicare. And that's been a really critical piece in us going ahead and achieving the reduction or the contract value that we have. So that was in phase 1. Phase 2, we went ahead and brought our claim processing in-house. That means we implemented QC, and that was for dates of service beginning January 1 of 2020. When we brought that claim processing in-house, we had probably a good 2 years of preparation. So we had Visium up and running for close to 2 years. We were working on configuring the QC systems to go ahead and administer the terms of our plan and process claims for all of the different ways that providers can go ahead and bill. And anyone that's ever had much to do with claims knows that when a provider submits a claim, they can submit almost an infinite number of combinations of revenue code and procedure code, and the system that we had in QC had to be able to go ahead and process that claim and drive that line to the appropriate benefit based upon all the variety of ways that they can. So that was probably about 1.5 years of preparation, was going ahead and bringing up QC. But we brought that claim processing in-house, continued to focus on our direct contracting with providers, and we also partnered closely with our clinical resources to go ahead and help get participants to the right providers or to the most appropriate providers. And when I say our clinical resources, I'm talking about not just care navigation, care coordination, that those are resources within the plan, but also our on-site clinics. After being in this space for several years, we have a lot of information about the success of a participant having services in one place of service or from one provider versus another. And so we share that information to kind of help identify, you think of it in the old lingo would be the preferred providers. So we think about identifying preferred providers from the space of not just price, the effect on plan spend, but also the outcomes. Are we getting them to the right person to drive the right outcome? And we've been using that information more as we've had the claim processing in-house and the pricing in-house. We have more information available to us to make that available to our clinical resources. With phase 3, we went ahead, and we are in phase 3 currently, and we will be in phase 3. That's kind of ongoing. That's just operations, normal operations. We're refining the system integration between all of our vendors, and specifically today what we're talking about is QC and Visium, but we're tightening up that integration, making sure that we go ahead and process the claims the way that we want to, the way that we need to according to our plan design, that the messaging is accurate. And Jeff and I'll talk a little bit more about some of those specifics in the next slide, but also continuing to direct contract, identifying spaces where maybe we need some additional coverage, or it's an older contract and the price is no longer consistent with what the plan is paying in other areas. So we're continuing evaluating the price, the effective price in the contracts that we have, and renegotiating those where it makes the most sense. So operational specifics, what are the keys to our success? And as I said before, price is critical. That's the most significant component. So we do focus on contracting. We will always focus on contracting and price management, both from the perspective of continued evaluation. Utilization changes over time, and so as we can kind of monitor those utilization and pricing trends and billing trends, then we can go ahead and take pretty quick action. We have our target reimbursement rates, which are Medicare-based pricing, both for our Alliance Direct and our non-direct providers. That's where we start. But that being said, we have over 600 contracts with varying terms. So some of our contracts, they're all over the place. We still do have some percentage of bill charges. We have very complex terms with carve-outs, per diems, bundled service rates, case rates, etc. And we load all of those to Visium, and Visium prices all our claims and then comes back to QC, and we're able to go ahead and have that information in QC and process and pay that claim according to the terms of all of our specific contracts. Contracting with Alliance is not just an advantage to the plan, it's also an advantage to the provider, and this has really been helpful to us when we do go and we contract with them, because we do pay 100% benefit. There's little to no member cost share to go ahead and chase. The statistics are that providers typically are actually able to collect about 18% of member cost share, and so having 100% benefit has been really a significant selling point when we go in and we're trying to direct contract with the provider, and we want to go ahead and have the rates that are target rates. There are some providers that have been really hesitant to enter into a contract at a percentage of Medicare, that when they look at the bigger picture, that they don't have to chase member cost share. We do turn around payments in about 8 days or less. We have very low denial rates. It makes it more palatable to them, actually more interesting to them as well. And I think they see the industry is changing with respect to looking at contracts that are based upon Medicare terms. The other benefit to our plan design is with 100% benefit, when a member goes to an Alliance Direct provider, that leads to really high utilization of Alliance Direct providers. So 80 to 90% of the claims that come in our door are for contracted providers. That is pretty significant, because number one, that means that we have negotiated rates with those providers. The other thing it means is those members are protected from a pretty significant balance bill. So we have been really pleased to see that members have tended to navigate themselves. If they are looking at going and getting services from a non-contracted or an Alliance non-direct provider versus an Alliance Direct provider, they'll go to an Alliance Direct provider most of the time, because they do not want to get a balance bill, and those are significant in the industry right now. In fact, most people, if they go to an out-of-network or a non-contracted provider, the 20% co-insurance is just a very small slice of the pie. What they're really seeing is the difference between plan allowable and the balance, the total bill charges is what's significant. So we also have been able to affect some of our referral patterns based upon partnering with our clinical people, care coordination, care navigation, and our on-site clinics. And that has helped drive additional membership to the right provider and to a contracted provider. As far as system integration, that having the tight integration between Visium and as the repricing engine and QC as the claims processing engine, we chose to do that integration via an API. There were a couple of ways we could do it, and we chose to use the API. And one of the reasons that we wanted to do the API is because in the past, when we still were using a third-party claims processor, it was not done via the API. So if any changes in pricing occurred, you would have to go, or you couldn't even have the visibility. You didn't see why a claim was pricing the way that it was. And once the pricing was in the claim system, it was there. So with the API, you get real-time repricing. Every time you clear and re-adjudicate that claim up until the time that it's set up for payment, it gets the updated pricing. So if anything changes on the other side with respect to pricing or repricing, you see those changes immediately. And I'll give you an example. We have had cases where we are in the process of negotiating a contract with a significant provider, and because we know that we're getting close to actual signatures, we may choose to, by mutual agreement, we may choose to go ahead and hold those claims so that we can process them according to the contract rates once the contract has been signed and loaded. In the past, what would happen is we wouldn't have a way, once the claim was in the claim system, we would not have a way to automate getting the updated pricing into the claim system. We would have to go ahead and manually reprice any claims that were received prior to the updated contracted rates being loaded with the repricer. Now we can just go ahead and stack those claims up in a queue. Once the contract is signed and the rates are loaded, we can just go ahead and clear adjudication, let those claims all reprice, and they get the most updated contract terms. And that's been a real advantage to us, not just in contract renegotiation or contract negotiation, but it's also been an advantage to us if there ever was a delay, for example, in, and those of you that are in, that are in this role, they know that sometimes Medicare isn't always timely in releasing fee schedules. And so sometimes when they release a fee schedule, it's almost effective after or before the claim came in the door. So it may have been effective 1/1 of 2022, but they didn't release it until too late to go ahead and get those fee schedules updated before claims were starting to be received. So that's another advantage that we have had with going ahead and using the pricing via the API. It also supports benefit configuration and facilitates our high auto adjudication rate. So our auto adjudication rate out of the gate, when a claim comes in first pass, about 80% of our claims auto adjudicate to an approved rate. And that's kind of been hovering between 78 and 82%. So 78 and 82% of our claims auto adjudicate to approval immediately upon receipt. And one of the reasons that that is significant, it's only good that you're auto adjudicating at a high rate if what you're doing is you're applying the correct benefit, applying the correct pricing, and you're all set to process that claim, correctly. And having the benefit configuration options within QC has allowed us to go ahead and very specifically identify those claims that for whatever reason we want them to stop or we need them to stop to ensure that they're processed correctly. The others, we can go ahead and let flow straight to an auto adjudication to approval rate and let those process out for payment without having to stop them. So the claims that we are stopping, the 20-ish% claims that we are stopping, most of those claims are truly claims that we indicated that needed to stop for a specific department to review. And that may be that may be the claims unit, that may be the contracting and pricing unit. That most of those claims are specifically stopped. There are a few claims in there that stop for reasons that maybe they can't find the right benefit or there's some sort of a conflict within the claim system. And we resolve those issues in QC pretty quickly, and then we don't have that problem anymore. So it's the 20% of claims that we want to stop, those are the ones that are stopping. Once a claim does stop, we have well over 90% plus of our claims that are in an approved status within 2 business days of claim receipt. So what that means is we're not carrying a really significant claim inventory within our QC claim system. Our claims, we do check runs once a week. So we are typically paying claims within 8 days or less from receipt. So a claim that's received today is typically going to be paid in the next week's check run. We also, as a result of the integration between the 2 systems, we're able to go ahead, and I said this a few minutes ago, but just to kind of give an example, I don't know how many users maybe have seen Visium. Maybe this is all completely new to them, but within Visium, you go ahead and get the full pricing details, understanding how and why a specific claim or a specific line priced the way that it did. And with the benefit of the API, that's all visible. So you not only see the pricing, but you see the claim edits. So if, for example, the pricing was reduced because of the rendering provider was a mid-level provider, you would go ahead and be able to see that within the pricing information in QC without having to log into a separate pricing system to identify why that pricing was not what the provider expected. And you'd be surprised how many providers call and try and get an understanding of, well, we thought we were going to get $100, you gave us $85. Well, there was a mid-level provider reduction, and our member and provider services have access to that information when they click on the claim within QC. It's one system to have up, and it makes things quite a bit simpler for them to go ahead and respond to questions, both from members and providers. I don't think that we really talk too much about this, but one thing that we have been using quite a bit more is price modeling. Visium has a modeling component that we can go ahead and use. We can run models. We can take select claim data and run models to go ahead and compare contracts, from one contract to another. If we have 2 providers in the same region, for example, and they have very different contract terms, we can go ahead and compare them and say, what's the difference? For the exact same services, how much would we pay for those services under these terms versus those terms? We use that quite a bit when we're trying to get an understanding of what is happening in the region and how much, if you look at a contract term, it'll say, you're going to pay this much for this service, but you really don't understand the impact of that until you see the claims that come in the door, how that impacts plan spend. So we use the modeling to go ahead and compare one contract against another. We also use modeling to go ahead and evaluate proposed terms. If we're in the midst of a contract negotiation or we want to renegotiate a contract, we can very quickly do some modeling exercises to see what the impact of those proposed terms are going to look like. I think, Jeff, I think I pretty much covered everything that I was going to. I think it's back to you.
No, yeah, thank you, and that was great. You really touched on a lot of the key points that made this integration successful. When Alliance and Payer Compass kind of met each other, it was clear that it was going to have to be a blend of both the direct contracting approach and reference-based pricing. Fortunately, that's directly in our wheelhouse, and for all the reasons that you mentioned. Can we jump to the next slide real quick? And I'll talk through some of kind of the nuts and bolts of how we delivered that. We've talked about the strategy, kind of blended together the strategy and then the perspective from the plan's perspective, and then kind of talk now about the solution itself and how it works. You've heard the term Visium used repeatedly today. Visium is Payer Compass's engine. It is our platform. It is our user interface online. It's almost synonymous with Payer Compass. So that is really what we do. It is a very robust claim and contract management system, as well as a repricing engine with an integrated modeling system that Al mentioned. So a lot of different things to talk through. If we could click through to the list there, I'm going to talk through a couple of the things that we've seen and talked about already, and kind of help to bridge the gap between what we did and how it was successful and what kind of value it drove for Alliance and how we did that. We've talked about edits a lot. Visium has a very robust suite there, and Al mentioned a couple of the mid-level providers. There's multiple procedure reductions. It's an infinite list. We support all of the Medicare. We have a number of state edits as well. We have a customization level there that is I think unparalleled in the marketplace. And it really, it does a lot of the blocking and tackling that you see in a traditional scrubber or clearinghouse. You know, we're doing a lot of that to make sure that the data that comes in is clean, and that when it marries to the pricing, you know, whether it's Medicare or a commercial term or whatever it might be, that you're seeing the appropriate reductions, that you're not paying those, you know, the discounts that Al mentioned on those items that might be packaged or otherwise considered. You know, it's a very easy way to integrate, and it's certainly something that is scalable. We can do it for an entire line of business, but we can also drive it down to the micro level of one contract, even a single case agreement, if it's got specific rules that might bend outside of the norm. So there's a lot of configurability there. In addition, it drives the remark codes that Al mentioned in QC. So all those things that help with workflow, the very specific buckets that might be out there to drive various processes downstream of us with Alliance and PLEXIS are very easily mapped. So we have these message codes that come out. You basically assign those to each individual bucket that then drive results beyond that. It's, again, streamlining that whole process and really making the specific workflow in that core administrative system of QC easier, so that you're not clicking as much. You're working towards that full automation that Al mentioned. It's a slick integration there. Al, would you add anything there?
I would, you read my mind. I would add something. The other thing that the advantage to mapping, having the Visium edits within QC, I'm sorry, bringing the Visium edits into QC and mapping those to QC result codes, is it also, and you have it in the slide, it allows us to go ahead and create specific messaging so that actually goes out on your EOBs and your EOPs to identify to members and providers why a claim may have processed or paid the way that it did. And that's
right.
that's an advantage. So even though some providers don't always see that, you can go ahead and map those both, you know, a Visium edit to a QC result code, and then you can map those to CARCs and RARCs to kind of have more, you know, explanatory information on your explanation of payments to both members and providers.
You bet. And I mean, the reduction of static on either of those channels is always welcome, right? The more explanation and transparency we can promote, the better. You know, that's the ultimate goal here. I mean, the current legislation notwithstanding, but we also have the ability to do real-time application. Al, you mentioned that the benefits, and I'm kind of blending two bullets here, but you know, finalizing those claims immediately, the ability to look at it and have that result in hand, as opposed to having to deal with a batch process where you're sending a file. The file has to return. There might be claims that pended for various reasons, and you have to have conversations, and it's a time chew. Instead of having a real integrated API channel where we can send a claim, that claim is producing results instantaneously. You're able to see the full process trail, which is within Visium a breakdown to the nth degree of exactly how a line priced all the way up to the claim level, along with the edit codes that are included. So you get a holistic picture really of how the claim was considered under the terms and conditions that are applied there. It's very powerful in terms of turnaround and driving those short timelines that you've got. The scalability based on customer experience and partnership, there at the great bullet point, you know, we have a lot of partners with PLEXIS, and as a result, you have the combined knowledge and experience of standing these instances up. You see a very unique instance with Alliance Coal here, direct contracting folded in with reference-based pricing. You're going to see the complexities on the next slide, and it was easy because we already had the pipeline established with PLEXIS. We both have experience. We both know what we're doing in terms of standing something up like this and where the pitfalls might be, so that when we have newer experiences like what Alliance was trying to do, it's very easy to avoid those and really focus on the core competencies and how we're going to drive that value for Alliance and other customers. We mentioned also the provider maintenance earlier. You know, we're all about having a single source of truth. You know, Visium makes that very easy. It's very easy for Alliance and the contract team there to get us that information, the TINs and NPIs that drive those mappings. And it can be robust. You know, it can be something that's exceptionally complicated with a variety of different TIN and NPI combinations that drive to various reimbursement configurations. Or it could just be, here's a TIN and here's the fee schedule, and that's it. You know, that is so easily driven within our system that it's really just an import process and then a level of QA as those rosters even out over time. It's something that's very, very simple, and it makes it so that you're not chasing 2 points. You don't have to manage that roster in Visium and in QC and another system, you've got a single source of truth that you can manage moving forward, and it's very easy to configure and keep up to date with maintenance. Big fan of that. I mentioned the off-the-shelf. The integration here is so easy because we know the pitfalls, because we know all this. Standing someone like Alliance up, standing a new customer up with PLEXIS has always been gentle. We know what our input and output look like together as partners. We know how that's going to drive workflows and really help to streamline the downstream process. And so it's very easy for us on our side in Visium to configure things for an optimal outcome for PLEXIS and the customers therein. I'm a big fan of that as well. And then, of course, the contract management piece of things, configuring the contracts. I mentioned how important it was that we were able to blend direct contracting and reference-based pricing. There's a basic in Medicare on both fronts, but without the ability to marry those terms and conditions to model and configure very complex contracts, you're kind of out of luck. If you can't get the price right, the conversation's over. We've talked a lot about price, we've talked a lot about editing, but marrying those two together and getting it right and accurate, if you don't do that right, there's a lot of Medicare-based derivatives out there, and if it's not what you say it is, you're gonna be dealing with more of that static. Can we go to the next slide real quick? There's some details in this one that I like. As we mentioned, there's a vast amount of direct contracts with Alliance Goal. As you can see, over 600 direct contracts. That's a lot. The power of Visium is the ability to take those various terms and conditions and marry them together in a single form, and then to scale it out from there. If we could bounce out to the next bullets as well. So not only are you taking a Medicare-based methodology, and we are based on Medicare. A lot of those in the marketplace say it's Medicare, but it's Medicare Light. It might be a cost to charge ratio. It might be some fee schedules, but it's not the full solution. We have a team of compliance analysts that are literally working around the clock to keep lockstep with Medicare. Al mentioned earlier, some of those rules and regulations are published retroactively. So we've got to be on top of that to make sure that we're lockstep in what we do and deliver in Medicare pricing, so that our customers like Alliance Coal can say, we need 160% of Medicare. No problem. We just assign that percentage and move on. You don't have to configure a million different dits and das and different points to make it work. You're just telling us what percentage it is, and we do the behind the scenes work and the heavy lift to make that work. But blending the traditional commercial terms in there is sometimes a challenge. So case rates, per diems, DRG rates, all of that can be shuffled together so that it's itemized either at a service level, a provider level. You can essentially slice and dice those terms and conditions however you want. And if there's a health system that has similar terms, you can then scale that out. So you take one and you tweak the OB rates for one provider. You tweak the default rate for another provider very simply. So you're not wasting time reinventing the wheel with each iteration of the contracts that we build. All of that happens seamlessly behind the scenes. Our contract team works, I would say, very well with Alliance Coal. I know that there's also the ability to lean back on QC if you need to for particular elements. I think, Al, y'all do vision and dental with QC so that it leaves the medical piece to Visium. So there's the ability to configure based on needs, whether it's within QC itself, or if you need to go the channel of maybe a slightly heavier lift with Visium to get Medicare and other things based on your terms and conditions for your various contracts. Al, would you add anything there? I feel like I've kind of rounded the gamut about Visium and the abilities there. Outside of the modeling piece that you mentioned, it is integrated. The real benefit there is that you do have the ability to compare. You have the ability to trend and project based on historical data and terms that you might have proposed or hypothesized internally. But what's better is if you like the rate, if it works out, all you have to do is push that into production, and then your pricing claims real time. You're not having to, again, reinvent the wheel or re-engage my team. It just seamlessly happens so that if it's approved, it moves into production. I'm a big fan of that. Al, would you add anything there?
No, the only thing I just would expand on a little bit is what you were saying about building and maintaining fee schedules in QC. That's always an option, and we do that. We use that selectively. Visium does price most of our claims, but there are some dental, vision, transplant contracts, single case agreements. We have elected to price all of those within QC and have the capability to do that within QC.
Yeah, the interoperability is great. And yeah, questions. I've run through it pretty quickly. I don't know if there's any questions. We're happy to field those, or if there's any in the chat, or after the fact. We can always be reached, internally as well.
I think you're muted. You're going to wrap up here.
There, sorry about that. Yeah, so at the moment we have no questions. That usually means that you've done a great job or everyone's asleep. My money is on the fact that you guys did a great job. So again, a great presentation, much appreciated. And to the audience, to the attendees, thank you very much again for attending. If you have any questions, you can of course contact Jeff through Payer Compass email address info@payercompass.com. You can contact PLEXIS sales team for any questions also, sales@plexishealth.com. And one last thing to mention is that we will be sending out emailing to every registered participant. We'll be emailing a link to the recorded version of this presentation as well as additional resources. So with that, anyone else got anything final to say before we leave?
Thank you all. Great job.
Yeah.
Appreciate it.
Thank you, everyone.
Have a good
Thank
day.
you. Great job. Have a great day.
Take care.